Good morning, everyone. Today I'm presenting our health economic model discussing the cost effectiveness of bladder management strategies in neurogenic lower unit tract dysfunction after spinal cord injury from a public funded healthcare perspective. Nothing to disclose. This figure showed the estimated incidence and prevalence of spinal cord injury in Canada, and these results indicate trends toward increasing cases of spinal cord injury in Canada over the next few decades, which clearly translate into an increase in the healthcare cost and healthcare utilization. The annual economic cost attributed to spinal cord injury in Canada exceeding 2 billion Canadian dollars. These figures showed that the largest cost driver to the healthcare system expenditure was secondary complications and hence hospitalization and inpatient rehab care. Urinary tract infections and other urological complications are the leading cause of hospital readmissions and have the greatest impact on healthcare utilization in spinal cord injury population. Neurogenic lower unit tract dysfunction is a chronic unavoidable complication in spinal cord injury and commonly observed up to 84% in this population within the first year after injury. And the principal goals for bladder management is to minimize morbidity associated with urological complication as well as to improve the quality of life. Recent guidelines advocate that assisted bladder drainage method selection should be individualized, and when possible, intermittent catheterization should be advocated over the other methods. So intermittent catheterization remains the gold standard bladder management modality in this population. While intermittent CIC is the gold standard, it's not without complications. Indwelling catheters, suprapubic or transurethral, have been frequently used in this population where self-catheterization is difficult, impossible, or inconvenient. Approximately up to 80% of this population would stop using intermittent catheterization after some time. Literature data showed a variability in terms of complication rates and the quality of life when comparing the three different management modalities, as well as most of the studies have focused mainly on a clinical and user perspective when comparing these management modalities, while the cost effectiveness and economic perspective of these strategies have not been studied so far. Therefore, this study aims to estimate the lifetime costs and the lifetime outcomes attributable to the bladder management strategies among this population, as well as to investigate the long-term cost effectiveness of CIC compared to suprapubic or urethral from a publicly funded healthcare perspective. So a Markov model with Monte Carlo simulation was developed using the Triage Pro software. We utilize a cycle length of 1 year and a lifetime horizon to compare the cost and the utility of three different bladder management strategies from a publicly funded healthcare perspective. The primary outcomes are cost per quality adjusted life years and life year gained. As we can see in this figure, that the study cohort has 4 different health states in this model: maintain intervention, switch intervention, complications related to the catheter, and death. This table illustrates the key input parameters we used in this model. Reviews have shown variability in terms of urological complications, quality of life, and compliance rate with the use of CIC, urethral catheters, or suprapubic. In terms of maintain intervention, the rate in the literature reported between 20 up to 79%. There is a huge variability. We use the figure 60% compared to 71% who will maintain using suprapubic or urethral catheterization. Among the catheter-associated complication, UTI were the highest among the urethral catheterization group, while urethral damage were higher in the intermittent catheter group. Death were an age-standardized mortality rates for this population. Here, the main cost inputs we used in this model. Estimated direct costs were assigned in 2019 Canadian dollars. And as we can see, the average cost for the first year utilizing the suprapubic catheter were the highest. And this is related to the initial cost of insertion. However, yearly thereafter, we can see that intermittent catheter are less costly compared to suprapubic and urethral catheterization. We assume that patients would use intermittent catheterization around 4 times per day compared to a change for suprapubic and urethral once per month. The cohort starting age for this model was 4 years. In terms of catheter-associated complication and the cost per event, we can see that the highest were attributed to major renal impairment and renal failure, and this followed by complicated urinary tract infections. Here are the results for our base case scenario over a lifetime horizon, and we can see that intermittent catheterization had a lifetime mean total cost of approximately 29,000 Canadian dollars for 20.9 quality adjusted life years. So our model showed that a 40-year-old spinal cord injury patient would gain an additional of 1.77 quality adjusted life years at an incremental cost of 330 Canadian dollars when utilizing intermittent catheterization compared to suprapubic. CIC also confers 1.9 quality adjusted life years and 3 life year gained compared to urethral catheterization at an incremental cost saving of approximately 2,500 Canadian dollars. This is a one-way sensitivity analysis which was performed for the key parameters that could impact the base case results, mainly the probability of catheter-associated complications which resulted in the great uncertainty. Similarly, we can see when comparing CIC to SPC that catheter-associated complication result in the great uncertainty for this model. Finally, this model concludes that clean intermittent catheterization is a dominant treatment strategy over lifetime. In other words, it offers increased benefit at lower cost. Despite the high ongoing cost of hydrophilic coated catheter, it was perceived as a cost-effective technology compared to other bladder management modalities. Suprapubic and urethral catheterization are minimally invasive, cost competitive, and they have acceptable long-term efficacy. Thank you.